newborn only must know. Okay, so only the most essential I think already I have rendered for your internal settlement. So only I have what is a must know for an undergraduate. Okay, so what is a normal neonatal? When do you say normal neonatal? Huh? So when the weight is more than how much? 2.5 kg and the gestational age is more than 37. Why this 37 is taken into consideration? It is a term, right? So another question is, if the baby is born on EDD, what is the gestational age of the child? Today, suppose today is 21st of November. The EDD of the mother is 21st of November and the baby is born today. So what is the gestational age of the child? It is 37 weeks, 40 weeks, 38, 42 weeks. What it is? So answer is 40 weeks. And you have studied in obstetrics. What percentage of babies will deliver on EDD? Only 4%, right? So if the baby is born on EDD, it means to say the gestational age of the child is 40 weeks. Suppose the EDD is 21st of December and the baby is born today. What is the gestational age of the child? So how many days before it is born? Roughly 30 days before, right? So 4 weeks before. So it will be around 36 weeks, around 4 days, right? So it is a preterm or term baby. So it is a preterm baby. So remember, ADD means the gestational age 40 weeks and not 37 weeks. Okay, so a term baby with weight of 2. Why this 2.5 kg has been taken as the cutoff? Anybody? Why 2.5? So anything weight less than 2.5 is considered as what? Low birth weight. Why the demarcation of 2.5? Why not 3 or 2 kg? Average. So if you measure all 100 babies, you will take the average. That is not the reason. So what is one more important thing? What is the definition of HJ, LG and So I told you, EDD is not 40 weeks. So what is AJ, AJ and LG? AJ means what? Appropriate for gestation. In exam they will ask very simple things. I am asking you only questions which are asked. Okay. So AJ means what? Weight of the child between 10th to 90th centile for the given gestational age. Anything less than 10th is small. Anything more than 90th centile is large for gestation. So tell me what is the 10th centile weight for 40 week baby? Roughly around that? It will cut around 10th centile, right? That is why the 2.5 stage is taken as the cutoff. Okay, so anything less than 2.5 is what? Low birth weight. So for a term baby, what? It is small for gestational age or appropriate for gestational age? If a baby is born at 37 weeks, so what? If a baby is, suppose the weight is about 2.3 kg, depends on the gestational age. But for a term baby which is born at on the 40 week, it is small for gestation. When you say small for gestational age, what are those babies which are included in that term? It can be a term baby which is small for gestational age, or it can be a preterm baby which is appropriate for the gestation age. Suppose a baby is born at 32 weeks, the baby's weight is 2 kg. So what it is appropriate or small? 32 meter. So it is 2. It is appropriate. But when you take the 2.5 as a demarcation for low birth weight, we classify the baby as what? Low birth weight, right? So baby is low birth weight, but it is appropriate for the given gestational age. So when you say low birth weight, don't be under the impression that all babies are small from gestational age. A baby which is low birth can be still appropriate for the given gestational age. Okay, so that is important. Okay, so please, what is toxin? I had already asked last time. Stops. You already also discussed. What is toxin? So very important. What is the any baby, sick baby? So any baby. So you are going to be doctors. At least what is toxin? Not right still. Okay, first is the abbreviation is TOPS. Okay, first is what? Sensorium. Sensorium of the child. T stands for what? These are the most important things that are expected from a until just know what is stop. Okay, stops. So oxygenation, perfusion, sugar, then other 3 additional need not, even if you don't also doesn't matter. That is one procedure, skin seizure and sepsis. Okay, so stops. So if any newborn when it is brought to you, you should assess the baby based on these things, whether there is a normal baby or anything abnormal with the baby or any lethargy or sepsis is there. Okay, so first is what? Sensor, very simple. What? Whether the baby is active and alert, or you see the baby is lethargy. Okay, so even when you discuss IMNC tomorrow, so IMNC told any infant is what? Less than 2 months of age. Even in that criteria to classify as what is big categorization in IMNC for less than 2 months, what it is called as if either hypothermia is there, fever is there, or the baby is not moving spontaneously, or there is decreased food, what do you call that? Possible serious bacterial infection, right? So any of the 10 criteria, if it is met, we classify the baby as what? Having serious bacterial illness. Okay, so sensory, whether the baby is active or whether the baby is lethargic. How to define whether the baby is active or lethargic? What will you look for? So you look for the tone of the baby, responsiveness of the baby, cry and movements of the baby. Baby should move spontaneously until another is sleeping, right? So after 2 to 3 feet, so the baby will definitely have. So some spontaneous movement will be the responsiveness. So don't try to orient it all for it. So I told you, orientation time patient person is after how many years? After 5 to 6 years. Even in a CP child 8-9 years, if he is having developmental age less than 5 years, you don't movement all. So when you are writing, even when they present with the CNS case, the child is active, alert, whether interested in the surrounding or not. Don't write child is awake, conscious also should not. Why conscious? You use the term awake, right? Why awake? Conscious means what? Aware of self and surrounding. It can be applicable for us, but not for us. So when you will see a child, you will say whether the child is alert, active, interested in the surrounding, responding to mother, playful, lethargic or not at all interested in the surrounding at all, right? So you should look for all these things. Okay, normal to response, go fast up. So lethargic means what? Baby can be floppy, baby can have poor response to your tactile stimulus. Baby doesn't move at all. With too much of stimulus only the baby is able to move. Now it can have a poor cry, decreased movement. So if this is the, what is the first difference in diagnosis for underage infant? A newborn has been brought to you with lethargy. The child is floppy, mother is not at all feeding. There is no spontaneous movements at all. So what are the first important difference in diagnosis? What do you think is the cause? The baby has become like this. For underage, very good. Sepsis. First answer should be what? Sepsis. That sepsis might be like hyperglycemia or it can be hyperglycemia, but how? So any baby which is not lethargic, the first thing I should tell is what? It is a possible case of a neonatal sepsis or a possible serious bacterial infection according to the IMC, right? Then coming to this already you will leave it. Then T stands for what? Temperature. Okay, so temperature is very, very important. So how do you measure temperature in a newborn? How do you do the presenters? Where is it? Come here. How do you measure the temperature in a newborn? How do you measure temperature in a newborn? In the exam. So tomorrow I will show you how to measure infant thermometer video. Okay, because you should not be confused. How to measure temperature in a newborn? How to measure? Anybody? These simple things again you fail to answer them. These things have been told already in neonatology classes. Everything has been told. How to measure temperature in a newborn? It is a thermometer or in oral cavity. Where do you measure? How many times you have to do? Where do you measure? It should be axillary temperature always. Okay. Until and unless it is. Sometimes you can go for rectal temperature if indicated. Because the rectal thermometer is not, it is a different thing and it is not universal available. So you can avoid that. But most of the definition ideally is based on rectal temperature. But you should say axillary temperature. I'll check it. Nowadays mercury is not developed beyond the digital. So you keep it for how many minutes? In the exam they ask you at least 2 to 3 minutes. Or in the newer digital one at least till the beep comes, right? When the beep comes means the temperature is not, it will not beep until the temperature stops to increase. You take any thermometer, digital, just keep it, it will keep on, the number will keep on increasing. At one point of time there is no further in the number, so it starts beeping. That means there is no further, that is the temperature of the patient. Again axillary, rectal, what it is. So when this, what is the normal axillary temperature in newborn in the asking the exam? So answer is 36.5 to 37.5 degree Celsius. Okay, so what is the definition of hypothermia? So just what is the simple diet method to say the baby is not having hypothermia? A pink soles and periphery. If you see any baby which is having a pink soles, okay, pink periphery, that means probably the baby is not having hypothermia, because the first hypothermic response will be on the cold stress, right? The baby will develop peripheral vasoconstriction, the baby will develop only peripheral sinus. What do you call that? Acro-cyanosis, right? So you see, if you see you are taking rounds in a newborn, if you see any baby's soles are blue, so what you should do? First thing is what? You think that probably the baby is having hypothermia. Okay, so cover the baby, get the hypothermosis. Okay, if you don't intervene, again the baby will go for moderate or severe hypothermia resulting all clinical manifestation. Okay, so when the baby is having soles, at least think that baby might be having hypothermia. That hypothermia can be due to other reason, but most of the time it is simple non-covering or non-maintaining of the warm chain, right? So 36.5. Then hypothermia. What is the definition of hypothermia? Any temperature less than 36.5, right? So you can just simple this. Okay, so what is the normal temperature I told you? 37.5 to 37. So this is what mild hypothermia, this is called as cold stress. There is stress on the baby, but baby may not be having any other clinical manifestations of a hypothermia. But if you have to pick up babies in this stage, okay, then if you don't intervene, so what is cause? It is a cause of concern. Okay, it is a cause of concern, that but doesn't mean the baby is in a danger. Okay, so what is called as moderate hypothermia? Moderate is what? This is mild cold stress. Cold stress is also called as what? Mild hypothermia. So moderate hypothermia is between what? 36 to 32 degrees Celsius. It is in danger. You have to definitely warm the baby. And what is severe hypothermia? Anything less than 32 degrees Celsius. Okay, so it has to be attended urgently. So what are the clinical manifestations? The time is there, we discuss. Okay, so thermal management also. So how do you warm the baby usually? What is the simplest method to warm the child? Cover the baby. Otherwise, most importantly, what you put the baby at a radiant warmer. Why it is called radiant warmer? What is radiation? Radiation means how the heat flows from the baby, either convection or what? Convection or radiation, right? So if the baby is exposed, cold air is flowing in front of the baby, the windows are open, okay, the baby is on a cold surface, so there will be transfer of the heat, right? So radiant means you have seen the radiant warmer. So there will be radiant heating coil, okay, from there the heat is transferred into the surrounding heat, that is called radiation of the this thing. That is why it is called as radiant warmer, or you can use an incubator setting, okay. So that is radiant warmer, we will come to that later, the time is there. Cover the baby, most important thing is, and switch off the ACs, everything warm environment has to be temperature. The room temperature has to be maintained around 26 to 27. So we leave that. Now this is what time? It can be both by mother as well. Again, kangaroo mother case is important question. It can come as a short form for 5 marks. Okay. So what are the steps to initiate, contraindication, what is the posture, everything, and what are the advantages of kangaroo mother? Okay, everything should be known. Okay. So you know why the terminology kangaroo has come, right? So moderate will leave. So babies will discuss later. How to increase the temperature. Then most important is what time? So we will come to this later. So 10 steps of warm chain. So warm chain again can be a question. Cold chain, reverse cold chain, and warm chain. Cold chain can be seen in transport of the vaccine. Reverse cold chain can be in acute flaccid paralysis. Right? The two tumbles from the person need to be sent back to the laboratory for evaluation. Then the concept of the warm chain. So what are the types of warm chain? Again can be a potential question. Okay. So this is what is this piece? What is called the blanket? So it is not a breathable blanket. Okay. So kangaroo mother care, that is not. And just making over. Then oxygenation, right? So O stands for what? Oxygenation. Okay. So when we say newborn, what is the normal insulin rate in a newborn? 40 to 60 or 30 to 60 also you can say, no problem. Okay. So in IMN say below what age, more than 60 is the cutoff? More less than 2 months, 2 months to 1 year, 1 to 5 years. Again, don't make this very fundamental mistake. 60, 50 and 40. If you don't answer anything, they will come to this very basic question. If you still don't answer, nobody can help you. Okay, less than 2 months is 60. Anything more than, equal to or more than 60. Okay, so normal respiratory rate is 60. When I say tachypnea in a newborn means the rate of the baby is more than 60. When you say respiratory distress in a newborn, don't confuse RDS with respiratory distress. Even in the exam, if the question is respiratory distress, it is not highly pneumatic they are asking. Okay. So when you say respiratory distress, along with distress, what is there? So they can be contained, they can be interactions. Okay. So all the use of accessory, clearing up, everything will be there. Okay. So again, why this is important? Saturation. What is the saturation of a newborn and birth in that newborn resuscitation algorithm? What is 1 minute? Algorithm is there, no newborn algorithm. What is the saturation at 1 minute of the baby's born at birth, and by 10 minutes how much you should be? So tomorrow is homework, read and come. I am only going to take it. So read NEONATAL algorithm because I am going to discuss that with the simulation. Okay, you should not know what is newborn resuscitation. Okay, so read completely what is the saturation at birth, and by after 10 minutes saturation should be more than 85 to 95. This thing, and what is important to write upon it, maybe pre-data. We will come to that later. This will you. I don't want to show person. Okay, so what are the causes for respiratory distress? So any of the plus or minus cyanosis. Okay, so any baby with respiratory distress is cyanosis. What is the possible etiology? They'll ask you. What are the possible etiology? You have seen a newborn, preterm or term. The baby is having distress and the baby is having cyanosis. Okay, what are the possible diagnoses? First, as a undergraduate, first divide the cause of what? Pulmonary. Non-pulmonary causes. In pulmonary causes, what are we considering? If it is a preterm, we consider what? High pneumonia disease or respiratory again I have seen students ARDS. Don't write ARDS for a newborn. ARDS is a totally separate entity. Don't confuse ARDS with respiratory distress syndrome of a newborn. In exam also the question will be there. A preterm babies are entered kindly dictionary the clinical feature, radiological and managemental. The first diagnosis will be ARDS. You lose the marks then and there itself. Okay. So don't write ARDS is a different thing. Okay. So that can be due to COVID, that is a different entity. So it is what a respiratory distress syndrome. That is due to what the pathological term is highly membrane disease. Okay. So write RDS. It is a premature. The hint is given. Okay. So if it is a preterm, it is RDS. Then what are the other etiology? So if the term any aspects can preterm. We can have aspiration syndrome. Then okay, very good. Transient kidney of the newborn. Then so most important sepsis I told you. It can be congenital pneumonia, late onset acquired pneumonia also. Then okay, pneumothorax all are rare causes. Then if you come to the non-cardiac causes, non-pulmonary causes, first thing will be what? Any baby with cyanosis. What is the first thing that comes to you as an undergraduate? We'll think of a cyanotic congenital heart disease. So yesterday tomorrow is talk for so we'll talk manifested but we'll come to that later. I think some will discuss. So what are the 5 things you will consider for cyanotic congenital heart disease? So tricuspid atresia or it can be visually present. Total anomalous pulmonary venous connection or a transposition of great arteries. We will all consider this, right? So how to know this, whether this test, because this question has not been given in your textbook but it was asked once in India University and I told you specifically to write it down and it was even discussed in the theory class, right? What test will you do to differentiate whether this cyanosis is because of pulmonary cause or whether it is because of cardiac cause? Hyperperoxia. What do you call the test? What is the name of the test? The question was asked in Indian University, but you are not in the question bank. Hypoxia test. Okay. What is hypoxia test? To differentiate whether the cyanosis is of pulmonary or cardiac etiology. Right? If you give 100% simple concept is what? If you give oxygen, if it is due to pulmonary cause, the saturation of the partial pressure of oxygen has to increase. That is probably. If it doesn't increase, probably it is a critical cyanotic congenital heart disease. Okay. So oxygenation is very, very important. Okay. So what is this score? What are the different scores you know of? Downing score is that you remember. When Silverman score is also that it doesn't remember also doesn't matter. Okay. So well looking that is there. Fluid. Okay. So possible etiology I told you respiratory distress syndrome. So what is this? So what is that? The entire lung has become white or brown glass appearance. And what is important you say? The entire lung. But what has happened to the bronchial cancer? The bronchioles everything is patent. The air is seen against the collapsed background. So there is air bronchial cancer with a brown glass appearance. What is the treatment for this? What is the treatment? You have to give what is deficient has to be given, right? So what is that to be given? So you have to give surfactant. How do you give surfactant? They will ask you next. Insure technique. What is insure technique? Intubate, you give surfactant, then extubate and put the baby on water. What is the most important other treatment? What is CPAP? Continuous positive airway pressure. There is no surfactant, the alveoli is collapsing, so you maintain a pressure both during inspiration and expiration, right? So the alveoli is prevented from collapsing, thereby decreasing the work of breathing. So you should tell water. So I will give surfactant by insure technique and I will be putting the baby on CPAP. That is very, very important. So how can you provide this? Not the steroids to the baby. You have to give antenatal steroids. Right? What are all the advantages of antenatal steroids? Very, very important question which can come as my last question. Okay. Okay. So this is what they are giving to the NGT. This is called Lisa technique that you do. Okay. So that will be. Then this is what. So that is what the other one. That is your congenital diaphragmatic hernia. So that will be. So this is central cyanosis. This is what a peripheral cyanosis, where center is not there. Okay, this also you. So P is what? Perfusion. Okay, so what can affect the perfusion of the baby? So simple is what? Capillary refill. Or you can say capillary filling time. CFT also you can write capillary refill time. How to do in the exam if they ask you? You can do it on the sternum and the forward, or even you can do on the source. Okay, you press for how many seconds? Okay, so you take your index or you press for at least 5 seconds over the sternum. You count 1000, 1000, 2000, 5 seconds, then leave it, and within 2 to 3 seconds you should be feeling up. So don't look at the watch, look at that. You should count in your mind like 1001, 1002 like that. So if it is, should be there. If it is delayed feeling, what do you call that? What are the etiology for that? The capillary filling time is prolonged. What is the most? If there is no perfusion in any patient, what is the most important differential diagnosis? Shock, right? Shock can be due to any way. It can be cardiogenic, it can be hypovolemic. So no matter what the underlying cause, the answer is what? The answer is shock. So what is the definition of shock in pediatrics? When do you say shock? Shock and hypertension in pediatrics. What is the definition of shock? So newborn, if the BP is less than 60, systolic BP. In infant, if the systolic BP is less than something, and 1 to 10 years. What is the formula? Lower limit of the BP. Age into 2 plus 17. So 5x means how much? 5 2s are 10. 10 plus 70 is 80. So if in a 5-year-old child the systolic BP is less than 80, that means to say the patient is having hypotension. 10 years and beyond 10 years, any systolic BP less than 90. Newborn less than 60. Infant less than 70. So 1 to 10 years, age into 2 plus 70. Okay, 10 years and beyond 10 years, including adults, any systolic BP of less than 90. So if I am having diarrhea and my BP is less than 90, so what I am in a hypotensive shock. If it is more than 90, still I can be in shock, compensated shock, but the pulse pressure will be narrow. I will be having fever, pulse, tachycardia, other things will be there, right? So this is what also shock. So another P is that this thing already told, right? So what do you do when the patient is having shock? Simple. What do you have to do? Taking shock, no, I will do, right? So what do I have to do? You have to give isotonic fluid. That is your fluid on your normal saline. What is the dose I told you during the class? You have to give 20 ml per kg. If 3 kg means you have to give 60 ml. So how many doses can be given similarly like that? Up to 60 ml per kg. 20 ml per kg 3 times. So totally is what? 60 ml per kg. Okay, so 3 elements can be given. If it's still not in what do you call that? Fluid refractory shock. Then you have to start the patient on what? Usually inotropic support, right? Then if it's resistant, we call as catheter resistant shock also, right? So most important is what? Sugar. Okay. So what is the definition of hypoglycemia in newborn? So less than 40 or 45, even if you be anything, will pass it, right? Okay. So what are the conditions when the baby can be hypoglycemic? Which are conditions predisposed to hypoglycemia in newborn? At least one answer. Infant of a diabetic mother, then smallpox, many other conditions, other sepsis, everything. Okay, everything can lead to this thing. Okay. So any baby is in neonatal hypoglycemia. How do you classify the baby? How do you classify the newborn? Whether it is symptomatic or whether it is asymptomatic. Why you want to classify that? Why you want to do that basic classification? Symptomatic, why you want to do that in the first place? So it is symptomatic means baby might be lethargic, you cannot be over, right? So I don't tell that I will prescribe to the baby which is having seizures or which is having a unresponsive state, right? So if it is asymptomatic means baby is still not lethargic, unresponsive, other manifestation of that. You can give a still a trial of oral fluids to increase the blood glucose. It is not that even those babies need to be put on a IV glucose, right? So that basic, usually less than 20 means they will be symptomatic. Even if it is asymptomatic, less than 20, preferably treat with as a intravenous dextrose. Okay. So what is the dosage I told you? I told you both hypoglycemia and hypocalcemia. It is the same thing. What? Both are 2 ml per kg. One is 10% dextrose, other is what? 10% calcium gluconate. In example, even in bio also they might give a calcium gluconate vial. Okay, or they can give a dextrose. So just tell what? 2 ml per kg. Of what? 10%. Either dextrose or either calcium gluconate. What are other uses of calcium gluconate? Anyway, calcium and dextrose will discuss in the class. So many other uses are there, including in hyperkalemia, right? So why do you give hyperkalemia and calcium gluconate in hyperkalemia? What is the rationale behind that? If you see that effect, that is the first thing to be given, right? So why? To decrease serum potassium or no? It doesn't decrease the serum potassium levels. Mainly it prevents the arrhythmogenic potential of your potassium, right? So that you should know. Okay. So indication that you know. Okay. Study that is not needed. Okay. Symptomatic means they have to be sick. Okay. That is mandatory. So what is the other thing I told you? Sepsis. Okay. Again, sepsis is very broad, but at least sepsis screening is an important question. That is very theoretical aspect. I told you again, clinical features of sepsis, how to screen a baby for sepsis. What are the four components of sepsis cleaner? Total or absolute neutrophil count. Total lymphocyte count less than 5,000, then micro ESR, then CRP and absolute neutrophil count. Right? If more than two of that, then like it. Then the most gold standard for diagnosis is what? Blood culture. So what is the duration of treatment in of neonatal sepsis? Again, simple question will ask you. If the baby is having sepsis, what is the duration of treatment? If there is only clinical sepsis, screen is positive but blood culture is negative, what is the duration of treatment? Around 7 to 10 days. If there is culture positive, no meningitis, what is the duration of treatment? 14 days. Meningitis means they will ask you only thing. Meningitis is what is the duration?
21
It
days.
is 3 weeks or 21 days. Don't forget, okay? So 21 days, 3 weeks, 2 weeks and 7 to 8, 10 days if the screen alone is positive without a culture being positive, right? So last is what? Neonatal seizure. I am in class also I showed what are the different types. What is the most common cause of the neonatal seizure I told you? Which we fail to recognize. What do you call that? Subtle, right? 50% of the neonatal seizures are what? Subtle. It can be just staying into blinking movements of the eye or over facial limber movements or just petting movements. I showed you all the videos. Listen. Okay, what is the second most common cause? Usually they are focal or generalized? Usually focal because the myelination is not complete. So the electrical potential won't, the discharge won't transmit to the entire brain. Okay, so most of the time in newborns, seizures are almost always focal in nature. So it can be focal, chronic or tonic, this thing. This is myoclonic. Right? So what is the most common type of seizure? Subtle seizure. What is the most common cause of seizure I told you? 50% are subtle seizure. But no matter what the type of seizure, 50% the etiology is what? I should cat my I should go on. Crocodile seizure how do you expect them to pass it? Crocodile seizure definition, fever 6 months at least age a fever history one newborn has come with seizure and if you label babies and crocodile seizure crocodile seizure can never be the diagnosis. Most important cause, I told you, what are the 3 important causes of death I told you? One is sepsis, prematurity, other way birth asphyxia, right? Birth asphyxia is what? 50% of what? Hypoxic ischemic encephalopathy, right? 50% of the newborn seizures are due to hypo. That is why you stress on newborn resuscitation. So when you go out, you should at least resuscitate baby, right? Then comes what are the other causes? They'll ask you, tell me 3 to 4 causes of neonatal seizure, doctor. What are the causes you tell her? So the most common cause is HIV. Then what? Sepsis, right? Sepsis, meningitis can cause. Then hypoglycemia is there. Hypoglycemia can cause. Hypocalcemia can cause. I told you both hypoglycemia, I told both are seizures. So both the treatment is 2 ml per kg, both are 10%, one way glucose, other way 10% calcium gluconate. What are the other possible etiology? Okay, you won't raise cause, don't tell me. At least for a PG. First answer what you will tell her? Sir, HIV, it can be sepsis, meningitis, then hypoglycemia, hypocalcemia and hypomagnesium also, right? So many other causes are, but at least HIV and sepsis as the first etiology. What is this portion? So if you see like this, what is the probable etiology? What is the portion? Tetanus. Tetanus. I only not seen tetanus after the MD. You are giving tetanus to all others. You say we are tetanus, all will also kick in. And the car is the evidence. And they should put cow down for the cord. Old parties, that is the tetanus. Now every mother is taking 20 doses. Very good. Third etiology, that is bilirubin. Encephalopathy, right? Bilirubin induced neurological dysfunction, right? So, what are the danger signs? According to WHO, newborn, they will ask you, tell me some important danger signs in a newborn. We should tell the mother. So, what are the danger signs? You will tell in the exam. One is yellow palms and sores, that is pathological term. Then, it is written there, any lethargy in the baby, if the baby is not active or lethargy. So, you have to counsel the mother, right? So, they will ask you to counsel the mother for danger signs in a newborn. That can be auscultation, communication signs. So, you will tell. So, you should tell first important point, any lethargy. Then what? Hypothermia. The baby is cold to touch or the peripheries are cyanosed. Then respiratory distress. Okay, the baby, the mother says the baby is breathing at a faster rate, it should not to be there. Any retraction. Then cyanosis, I told you then. Any history of convulsion. Okay, then abdominal distension. Okay, what are the causes of abdominal distension in newborn? What are the causes? Hydroxypyritis. Huh? What are the, if a baby has abdominal distension, what do you think? Obstruction. Okay. What the obstruction? J obstruction. What obstruction can be there? Esophageal obstruction. What obstruction? Abdominal. Holes there. Better. I look as it is other causes. Okay. Now only think GA. Okay. GA obstruction is more specific. So what are the causes? You GA becomes discoitis. Meconium should pass within how many hours? Okay, usually 24 hours, but you can wait up to 48 hours, especially in preterm, or it makes no abdominal distension. What are the causes for non-passage of meconium? Most important surgical cause for J obstruction is what? Your Fishman's disease, right? Then don't tell intersusception first. What are other causes of abdominal distension? It can be imperfect anus, right? Yes or no? Then imperfect anus, what you are eating? What do you take? What do you do for imperfect anus? You to suspend the baby, put a coin and take an X-ray. What do you call that? Inotogram. So it is showing how much people are reading. Your answer is proportional to your quantum of reading. So it is not matching it. So both are lesser. Neither reading is happening. Okay, leave it. Still time is there, but do read up. Okay, so it can be any cause of J. It can be duodenal atresia. Okay, it can be volvulus. It can be anything, right? So duodenal atresia commonly can be seen in a Down syndrome. If a Down syndrome baby is there, abdominal distension, vomiting, bilious, especially this thing. So whether baby will see non-bilious vomiting. So it will present at birth or when? What is the usual age of presentation? Usually it will be 3 to 4 weeks. It doesn't. That is why the congenital is misnomer, right? Abdominal distension. So in a preterm baby, if there is abdominal distension, what are the things I can do? One. So it is necrotizing enterocolitis. Okay. So I told you to add that also. What are the complications of IUGR baby? What are the complications of the? So another important question they will ask you. So tell me 3 complications of the IUGR, 3 complications of a preterm baby. You should be in a position to tell. Okay. So feeding abdomen, what feeding is the important they will ask. Certain necrotizing enterocolitis. Okay. So bleeding neonate. Any bleeding anywhere is there, always a danger sign. It can be due to sepsis or due to many other things. Okay. Vomiting and diarrhea and newborn. Okay. So all these are important danger signs. Okay. So come back to the case presentation. Come first. 3 points enough. So it should not be a quick color. It appears after 24 hours. Then second point. Unconjugated is forms and cells should not be involved. Okay, then. In the very I told you, is that why so serious? Why you should be serious at this now? You are seeing that. Are you serious or not? That time why you are serious? Because looking like a yellow banana, yes or no? And the yellow banana will take your heart rate will increase. Yes or no? So it is definitely. You should be serious. Which movie is that at least? Joker, end of movie. Batman. Okay. So I told you it should occur after first 24 hours. Okay, so no evidence. Right? When does the baby appear jaundice? If the bilirubin is more than how much I told you? 5. For baby to appear jaundice, 5. For us, how much bilirubin is needed to appear jaundice? 2. For skin mucous membrane, it is 2. Skeletal jaundice are 3. Okay, for the baby to appear jaundice, it is to be minimum 5. So if you see baby jaundice from day 1, that means bilirubin is more than 5. Any baby which is born should have a bilirubin of less than 5 on day 1. Okay. So it appears after 24 hours, peak on 4 to 6 days, and usually disappears by 10 to 14 days, depending upon preterm or term baby. Usually term babies will disappear by 7 to 10 days. Preterm babies will disappear by 10 to 14 days. And what is the peak level according to physiological limit? Usually it is about 12. Okay. So you should say, sir, the jaundice is occurs appears after 24 hours, usually peaks between 4 to 6 days, usually disappears by 10 to 14 days maximum, and the peak physiological limit is around 12 milligram. Okay, so what is pathological then? Simply apply that concept. What is the pathological jaundice? So make a reverse. Okay, reverse is what? Visible jaundice on day 1. That means to say first day bilirubin is more than 5. Okay, what is the second criteria to say for the I told you, any jaundice starting on day 1 is always pathological. Any jaundice starting after day 2 is what? Usually physiological, but it can be still pathological. And don't be under the impression that all pathological jaundice have to start on day 1. Any day 1 jaundice is always pathological. A jaundice after day 1 is usually usually physiological. Okay, but it can be still pathological. Okay, it has started after day 1, but if the baby's jaundice even after 3 weeks, it is abnormal for the baby. It is not physiological. Oh, don't say that baby did not have day 1, so it is physiological. Don't send the baby home. Okay. So second point is what? I told you the rate of rise is more than 5 milligram per deciliter per day, or 0.2 deciliter, usually 0.5, but ideally is 0.2 milligram per deciliter per hour. You have done bilirubin today, it is 5. Tomorrow you have done it is 12. What has happened? In one day it has increased by 7. That means to say why it is increasing? Either there is increased bilirubin distraction, right? Something is abnormal in the baby. That is why the load is increasing. Second point is what? The physiological limit. How much I told you? 12. So it is 18, 20. It is not normal for the baby, right? When you plot on the nomogram, so it is very much beyond the considerable limit. So in simple OPK definition is what? More than 5 on first day, more than 10 on second day, and more than 12 to 13 thereafter in any term. In a term, baby, preterm you have different criteria to apply. But just for an undergraduate, when is pathological? More than 5 on day 1, more than 10 on day 2, and more than 12 or 13 after any time after that point of time. If you see 7 day, 8 day, 10 day, if it is more than 12, on day 1 is always pathological. Okay. So even if you see that, you consider this is the simple. The concept behind is the rate of increase is more than 5 milligram from day 1 to day 2. And if it is not increased, but it is persistently more than 12, even after substantial period of time, you still, what is this staging called as a famous staging. That we should know. How many zones are there? 5 zones. Zone 5 is what? Pumps and sources. Pumps and sources mean what does it mean? It is more than 15 to 20. Okay, so just remember that much. Okay. So I told you. Okay, so what are the other criteria I told you? We leave this. So other things is what? Direct component. The direct component should be, what is our bilirubin normal? It is 1. How much is the direct component? Usually less than 0.1 to 0.2. If the direct component is more than 20% of the total, then there is something seriously abnormal with the baby. What do you think if I have a cholestatic jaundice? What do you think the intelligent diagnosis usually make? You can make also viral hepatitis. You can make any diagnosis. But what do you make a diagnosis in a newborn? If there is a cholestatic jaundice? So you think of other causes. Johnson, I told you, one important Krigler-Nazar and your Gilberts are unconjugated. Direct DR is there. DR means 1D stands for Dubin-Johnson, other R stands for Watterson. Instead, Dubin-Johnson, Watterson are most important diagnosis of what? Biliary atresia. Okay, so all these people there, you say consider to be this thing. So in I means here. So when you say only jaundice, when you say severe jaundice, you tell me when the age of the baby is less than 24 hours, age is 14 days or more, and if the pumps and soles, no matter what the day of life of the baby is, right? So if you see jaundice in any baby on day 1, or if you are seeing a baby which is more than 2 weeks still jaundice, or if you see any point of time the pumps and soles are jaundice, you call it as what? Severe. In exam they ask you, when do you say severe jaundice, doctor? What will answer be? So any baby which is jaundice from day 1, if the jaundice is present beyond 14 days, and if the pumps and soles are, this is very simple. Don't do anything beyond, just tell these 3 important words. Okay. So nothing is matter, you just label it as jaundice. So again, what are the causes for pathological jaundice? In exam, if you ask, what are the causes? So name 2 causes for first day jaundice. They will ask you. What are you tell? Okay, it is isolated or non-isolated. Isolated causes are there or no? RH, right? RH incompatibility or AB or impaired. AB will be other is O positive, AB is either A or B positive, right? Or it can be other minor blood group companies. Or what are the other causes? Non-isolated causes are mainly G6PD, pyruvate kinase, deficiency of hereditary sperm. All these can cause in hemolysis, right? So tell these important causes first. Okay. Okay, present the case. Again, phototherapy is also very, very important. And how to assess jaundice, I told you. this is like a yellow banana. So you can spread over the, so in the exam if they ask you assess for jaundice, so you can spread over the forehead, then you can press over the nose, you can press over the chin, over the sternum, over the abdomen, like this. You can spread the skin or just give a deep blanching of the tongue, then look for, so jaundice for palms and soles. The palms and soles are don't keep on looking this, palms and soles itself will stay. Famous soul says that it started from head only, so don't keep on looking for hiccups in the head, okay? So that is important, so you should do like this.
Translate Mrs. Monisha, age 20. Mother's name Mrs. Monisha, age
So the
28.
blind photo both are sent in the group, okay?
Mother's name Mrs. Monisha, age 28 years, LLB 25 to
What is
41.
the gestation age of the child? You tell me here. You forget, it is already written now. Okay. So 3 down, so 25. So the date of delivery was 14 years. So how many weeks before roughly? 3 weeks before. That is why the gestational age 37 weeks. Okay. So EDD means 40 weeks. So just remember that much. Why age of the mother is important? Okay.
Obstetric history P2 L2, past pregnancy, last childbirth 4 years back by LSH at 40 weeks due to breech presentation, birth weight 2.5 kg, girl to be alive or birth.
Why you want to take the history of a previous child? Why does it matter? Why does it matter? One is the LSA. If they done LSA, so the first question is whether previous is also LSA. But coming to the baby aspect of why you want all that history? What is the reason for asking that history? Previous? Suppose these babies have a distress, the previous also had a distress, okay, or mainly jaundice, okay. So any previous sibling or distress, prematurity, so previous child with any syndromic, so those things, whether the baby was alive or dead, whether any admission, so that will hint whether any problem can occur in this present baby. Okay, now continue. Especially if the mother is AB or RH incompatible, okay, if the previous baby is having significant jaundice, having done extent transfusion, so you should be knowing prior that this baby is also equally likely to end up in a significant or severe jaundice. Okay.
Present pregnancy, antenatal period, first trimester, pregnancy confirmed by UPT. She is a book pregnancy. She is a book case.
What presenting they are also, there is no need, if I ask you to present, they will also laugh at it. So why you are making you present actually right case sheet? So this is the same thing. So you all copy when these things are given and you end up like this.
She is a book antenatal case. Folic acid never taken. No history of fever with rash. No history of radiation exposure.
History of a fever with rash? What is the reaction of fever with rash?
Infection.
What infection you want to ask? Mainly torch infection. Okay, again because they already discussed congenital rubella syndrome. Even fever during pregnancy itself is a teratogen. Okay, and especially if doctors prior to delivery also, it can result in neonatal depression.
No history of radiation exposure. No history of detecting.
Okay.
Second trimester, and folic acid tablets taken. Arm scan taken. Beginning for the 18 week. 2 doses of TD taken at 4 weeks apart. No history of gestational diabetes mellitus or hypertension.
So what are the effects of diabetes mellitus, gestational diabetes mellitus on the baby? I am already asking what question they will ask. So next question, right? What is the effect of over diabetes? Don't compare over diabetes with GDM. Okay. So over diabetes can present with even critical congenital heart diseases also, right? Sexual age, and don't tell those as the clinical method. Here usually GDM alone means usually they have a large size, microsomia. When do you say microsomia? More than 4.5 kg. Last for gestation is more than 90th centile for the given gestational age. Okay. Then usually what will then they'll ask you what are you going to monitor after the baby is born. What will you monitor? During birth, because of large baby, the baby can have birth injury, trauma, shoulder dystocia, it can have fracture. So many things can be there. But usually what you will monitor as an intern after birth? You will monitor for activity of the baby and you will monitor the blood glucose of the baby, whether the baby might develop in a symptomatic hypoglycemia. And what are the other metabolic abnormalities can occur? Electrolyte can occur, hypocalcium and hypomagnesemia. Okay, now continue.
Third trimester, no history of bleeding the vagina. Growth can taken. Antenatal steroids taken.
Again, tomorrow's homework, read everything about antenatal steroids. What are the advantages? So it is basically uneventful. Okay, next.
Labor and delivery, hospital delivery, elective cesarean at 37 weeks, 4 days. Indication for cesarean, previous LCS. At date of delivery, 14/11/2024 at 9:35 a.m. Baby cried soon after birth. Upcast smoke at first minute, 8 by 10.
Again, you should know upgrade component. So R stands for what? Respiratory rate. Rate, how will you give score of 0 and 10 in Abgas? Tell me. It is rate. Again, now I am asking you because these are the things which the students usually. It is rate or what? Rate and what is R stands for? Same ide. Law can film, but rate and so tomorrow is fine and it is not rate. It is respiratory effort of the child. So tomorrow how to give Abgas score? Abgas score less than 7 and 1 minute is important. Okay, it can be defined as birth asphyxia. Continue.
Baby's blood group B positive, mother's blood group O positive. Postnatal period, breastfeeding started soon after birth, urine and liquid crossed in 24 hours, BCG, hepatitis B, OPV given.
Again, most important, vaccination. I told you how many doses of hepatitis are given. Last class we couldn't tell. Total how many doses? 4 doses including the birth dose. Okay. And which are intradermal, which are this thing, everything should be known. And when the BCG is correct, what is the sequence of events? Again, they will be asking. Then,
vitamin K supplement.
Again, I told you last class why vitamin K has to be given. Okay, what is the rationale, what is the hemorrhagic disease of the newborn, what is the dosage, and what is the concept behind vitamin K dependent clotting factors. Okay.
Jaundice appeared on the same.
So appeared on day, second day. So it is physiological or pathological? Usually it can be most likely physiological jaundice because mother is O positive, B positive, baby was O positive. ABO means mother should be O, not baby should be O. Okay.
No history of seizures, respiratory distress, fever, family history notes, significant family history.
Okay.
Personal and social history, breast milk given, sleep adequate, bowel and bladder problems normal, lower medical lower middle class according to modified personal history. General examination, birth weight 2.52 kg, sex female, gestational age by LMP 37 weeks 4 days, by expanded colostrum 36, which is 38 weeks of consideration. Term baby.
So what is this blood score? Again, most important prematurity and it's given in OPG and next to the pictures. Okay. So what are the components of blood score they will ask? You don't need to remember the score. One is physical maturity, other being the neuromuscular this thing, right? And at least as an undergraduate, even if you don't know neuromuscular, at least you should know the physical maturity differentiation between a preterm and a term baby. Again, read tomorrow I will show you how to do that. Okay, so blood scoring system. Okay, then.
Term baby, Monroe index.
So what how to calculate Monroe index? What is the formula? Weight in grams divided. Weight in grams or not in kg? Divided by height in. Don't say height. Length in. Again length. So length in centimeter cube. So what is the importance in a normal baby? It will be more than 2 or less than 2? It is no. Yet normal baby no. What is there? More than 2. It will be less than 2 in which babies? Symmetric or asymmetric? In symmetric age what will happen? Symmetric means usually the onset is before the 20th week of gestation, right? So what will happen? The size is also, the number also will decrease. So weight and height both will get affected. So numerator and denominator will proportionally be affected. So when both are decreased, what will get a ratio more than 2. Whereas in asymmetric age, what will happen? Only the cell size will decrease. The cell number remains the same. Okay. So what is going to happen? The weight alone will decrease. No, it's not much effect on the length of the child. The denominator remains higher, whereas the weight of the child will decrease. So when the denominator is more, the ratio will become less than 2. Whereas in symmetric areas, both are proportionally affected, so the score remains more than 2. The index will be more than 2 itself. Okay, now continue.
Anthropology. Postnatal day 3. Weight 2.52 kg. Length 47 cm.
What is the normal length of a newborn? Term baby? 50. It will double by what age? 4 years. Double of half we already studied, right? So this is I told you, each month how much?
Circumference 33.
So what is the normal head circumference of a newborn? 33 to 35. Again I told you how does it increment. Okay, first 3 months, 2 cm per month, everything I have told you. Okay, and how to measure also, tomorrow I will do a video demonstration. Okay, chest circumference. Why it is important chest circumference? Normally it is normal or abnormal? What is the comment here? They are saying normal. Is it normal or abnormal? So when do you take it as abnormal? Usually, which is lower? Chest circumference or head circumference at birth? Just will be low, usually by 2 to 3 cm. It is normal. Then it will equal by 1 year of age, and thereafter chest circumference will exceed the head circumference. Usually high age and all, the difference will be more than 3 centimeters. That is why you have to measure the chest circumference. Okay, next. So again he has plotted here, very nice. So 37 weeks, 4 days it was. So it is 2.6. So what it is? It is appropriate for gestational age. So don't get confused. What is AGM, SGM, LGM? Okay.
Vitals, temperature 36.8 degrees Celsius.
So you should know how to measure. They will ask you how did you measure the temperature. So you should say axilla waited for at least 2 to 3 minutes until the beep was heard. Okay.
Respiratory rate 50 cycles, 54 cycles per minute.
Like this, or you can keep it like this, but don't overshoot. The point should not be beyond the axilla. Okay. So don't push it and see where the tip is.
Heart rate 130 beats per minute.
What is the normal heart rate in a newborn? More than 60. No more the answer. What is the normal heart rate? 122. Even in water come also 122, 160 is the normal. Up to 100 you can wait. But ideal heart rate is around 122, 160. Right? 100 to 60 also acceptable.
Oxygen saturation on right upper limb 97% and lower limb 97%.
So usually blood pressure is not no need to tell in the final exam. You say do not be measured. Nobody will tell you. Your PCs also will find it hard to measure blood pressure in a newborn. Okay, you can just omit that. Okay. So just say peripheries are warm and pink and they still capillary filling time. You should know where to press 5 seconds, leave it. For edema, how much little ankle edema? At least 20 to 30 seconds, that is the normal answer. But very obvious edema, even 5 seconds is also good enough. Okay, for dorsal edema, how much seconds to press? I told you. For SAM, how many seconds will you press? 10 seconds, 20 seconds, 5 seconds, how much will you press? That's the difference. How much seconds you have to press? Already told in the class. It is, I precise 3 seconds, but at least you say please don't press for 10 seconds for a SAM baby. Just press for 3 to 5 seconds. Okay, with the thumb just press over the dorsal of the foot for 3 to 5 seconds. For ankle edema, it is 20 to 30 seconds. Okay, for CFT it is around 5 seconds. Okay, and it should refill by less than 2 seconds. Next.
Signs of distress.
What are the signs of distress you look for? Just for revision. What are the signs of distress you look in a child? In newborn? Rate. Distress. Tachypnea is different. Distress. Tachypnea for various features in the child. You say baby is in respiratory distress. Grunting. You know what is grunting? Any interaction. Cyanosis, mainly flaring of the air. Use of accessory muscle should be there. Then.
Jaundice is present. Grammars, dermosome, jaundice,
what is the zone? Trunk. What is zone 2? Upper chest. But trunk and head. So it will come upon zone 3. Okay, so zone 3 is usually what? No. So remember at least zone 5. No pallor is there, no cyanosis is there. Okay, what is the normal hemoglobin in a newborn? It will be higher or lower than the It will be higher because babies in a little hypoxic state, right? So it will be around 18 to 20, 22 is also normal. So very high hemoglobin and increased hemoglobin. What do you call that? What do you call that in a newborn? Very high hemoglobin. If IDM baby or babies have severe intra-uterine growth restriction. Polycythemia in a newborn. So hematocrit more than 65 in a newborn is called as what? Polycythemia, right? So what is the treatment for that? If they ask. So in bilirubin we ought to do double volume exchange. What is the volume of blood in a newborn? I told you. It is 80 to 90 ml per kg. 3 kg baby andre 3 into 80 will be 240 ml. So you take double of that, 480 ml of blood, then you exchange it. Okay, so you are exchanging blood with blood. That is called as what? DVT, double volume exchange transfusion. Here excess blood is there. You have to remove that blood and put it to replace with normal saline. That is called as what? Partial exchange transfusion. So PET and partial exchange transfusion, which is done for polycythemia. Double volume exchange transfusion is done for what? Here bilirubin, severe bilirubin. It is not responding to phototherapy. Then
head to toe examination. No facial dysmorphism. Head normal. Anterior frontal open to normal. It is 2.5 to 2.5.
I told you how to measure the dimension. It has to be diagonal. Okay, when it will close 9 to 18 months. Then what are the causes for delayed closure, wide open, everything I told you read from Melman Singh. Okay.
Posterior fontanelle.
Usually posterior fontanelle will be very small opening. Okay, it will usually close by 2 to 3 months of age. Okay, if it is wide open, what I told you, it is an important indicator for what I told you, congenital hypothyroidism. If the PF is more than 0.5 to 0.5, it is an important indicator for hypothyroidism. Then here's everything look equals okay. So everything is mentioned. Okay. So what are the common normal variants which can be seen in newborn? Common variations. You know, like if you see Mongolian spots, it is normal or it can be abnormal. It can be normal. Similarly, anything abnormal, which are normal manifestation of physiological variations? Erythema toxicum, good then. Inclusions is then. Even discharge, white discharge or blood discharge in a female child is also normal. Okay, that is not investigate for bleeding neonate in that babies. Okay, continue.
Systemic examination, cardiovascular system, as well as to give no over, respiratory system.
So again, abdomen organomegally. So usually children's I told you. So liver will be palpable in smaller children. Okay, up to 2 centimeters below the right costal margin. And any organ when you are palpating normal and always the consistency will be soft.